Thank you, Sean, and very good insight, certainly for me, in terms of the psychological, biological and social issues that can interact. Very insightful indeed. I'm really sorry about the rats, and I'm even more sorry about Mayo. Okay, Dr. Gerry McCarney is going to join us now. He's an experienced addiction psychologist, particularly focused on working with, psychiatrists, apologies. I always get them mixed up. But particularly working with young people in addictions. So, Gerry, over to yourself, and thanks for your time today.
Thanks very much, Paul. The main difference is a couple of extra years in college being very poor between those two. I work within the addiction service in North Dublin, and we work almost exclusively with under 18s who are engaged in substance misuse. We also try to help them with some other addictions, but the first slide here is brain development with age. I'm not going to get into it in detail, but the main point is during that time, most of them are developing physically, emotionally, socially. Their peer group has become a bigger factor in their life and their decision making than their family, and they're dealing with lots of change. It's also the first time for many of them they may begin to have mental health difficulties, and it's also the first time when they, for most of them, will engage in substance misuse. Putting it into that context, why people use drugs, most of the young people we would see are in the first three, kind of at 12 o'clock, 2 o'clock and 4 o'clock. They're experimenting. Then if they like it, the hedonistic element, they keep going because it's fun. They don't do it because it's not fun. And then the social and peer group, as I said, the impact is maximal during that time. You probably remember yourself. And so, a group activity can be a lot of fun, but also it encourages you to continue even if you're having second thoughts yourself. Sometimes we see young people who are moving on into the other sections then. Compensatory use, particularly if they have mental health difficulties or they think they don't fit in or whatever. And when it becomes habitual use or they become dependent, it's much more significant and more difficult to manage. So we see young people involved at all stages. And for some drugs, they may be at one stage and another drug at an earlier stage. And obviously the focus for us in the harm reductionist model is to try to move them back and move them away from the more serious aspects. This slide with a significant acknowledgement to Banksy, in a way captures what drugs can do to you. For a young person with lots of ambition, lots of dreams, lots of hopes, lots of potential, be it in the academic or sporting or social or whatever aspect of their life, drugs can cause a significant impact. For most young people that we see, the drug of abuse, the first one to start with is cannabis. The one they're using mostly is cannabis. So it has a significant impact on how people function and on how they progress. So this is important because I suppose any drug can affect how you think, how you feel, your ability to reach your potential. For young people we work with, that means whether they're going to school, whether they're applying themselves, whether they're doing well in exams, whether they continue to go to school, whether they drop out, their relationships at home. And so when they refer to us, all of these aspects of their life can be problematic. That means then we're dealing with families, we're dealing with schools, we're dealing with lots of different services that may be involved. Which is why we have this model here. And this is taken from what we call the Blue Book, which was around from the kind of the turn of the millennium. It then was somewhat replicated in A Vision for Change, which was, as we know, in the noughties. And then we're left with it still being very relevant today. And so this underpins the under 18 aspect of the National Clinical Programme for Dual Diagnosis. And it's a 4-tier model, and services would come in at tier 3 in the community and tier 4 where they have inpatient or residential treatment for young people for whom substance misuse is significant. But tiers 2 would be services who have, I suppose, experience or expertise in the area of either substance misuse or mental health issues with young people. And tier 1 would be any other service working with young people who may not have experience or expertise in those areas, but work with young people. That's just this model, but the point is that developing services for young people means you have to work and support all the other tiers, and we can't work in isolation because all the other tiers help us, I suppose, manage to have an impact at a local level in the service. And the Tier 4 piece is crucial for those who have significant difficulty and may need to be, I suppose, removed from the environment they're in, removed from the queues, etc., to give themselves a chance to start again. When you look at the stakeholders, this is a kind of just looking at our own service, the SASSY team, which is Substance Abuse Service Specific to Youth, which is the pilot project under the National Clinical Programme for under 18, and that's based in North Dublin. We cover all North Dublin City and County under 18s with substance misuse. If you look at the number of stakeholders, it matches very clearly the tier model. At the community level, you have all the local communities who are working with children who have difficulties in relation to substance misuse, but also the schools, also the kind of support programs, sporting activities, etc., and the families and friends. And then you have all the kind of professional ones in green, and then you have the non-kind of medical, non-mental health ones that are also relevant. So the model is there. It has been working. We've been doing it for some time. This is just the next few slides are just going to give us a quick idea as to what we're seeing. So these are from the 118 new clients that we saw last year. There were 3 of us working in the team at that stage. Thankfully, we're recruiting this year. We'll have more so we can do more. But this is kind of at referral, the age. So the youngest person was 12. We've had a few 11-year-olds referred over the years. We've not had anybody younger than that. But if they're referred to us at 12, you can be sure their drug use started at an earlier stage. So most of them were 15, 16. This year's stats to date have shifted that to the greater number being 16 or 17, but it's always fluctuating from year to year. But the point being that some people present at a very early stage. The maximum number would be probably 14, 15, 16, 17. Age of first use then, when we see them and assess them and we ask, there's always a lag period of at least 2 years, sometimes 3 to 4. So you can see there was one case where the young person began to experiment with drugs at the age of 8. That's not the only case we've had of that. We've had a few, 8, 9, 10 over the years. Most of them start, as I suppose with Anne-Marie's stats, kind of 14, 15. You see that there. But there are some who are outliers statistically and start at a very, very young age. And then you're looking at high-risk situations, access, and attitudes being very, very important. Drugs of choice, while I suppose cocaine has become maybe the reason why more people have presented to treatment services than any other drug, and that's a recent change. For young people's services, for many years, cannabis has been the reason. And so, as you can see, out of 118 new clients last year, 99 had cannabis use as a significant problem at presentation. Alcohol has always been second, and then cocaine and ecstasy tend to swap places over the years. Last year they were equal, and we've seen over the last few years, I suppose, an increasing problem with nitrous oxide. It's been in the news a lot, and we have, I suppose, we've had contact with the ED departments in our area because young people are presenting with neurological difficulties, movement difficulties because of the frequency of nitrous oxide use. Ketamine has been probably a big favourite, particularly up here, actually, in the kind of North Dublin County area, and particularly in the summer months for about 10 years now. So it's definitely on the radar. Benzos traditionally haven't been as big a problem for younger people, but in their 20s, etc., people tend to use it more if they're coming down off coke or coming down off opiates. Hallucinogenics, again, there seems to be a seasonal variation here. So, LSD and novel substances, they're lower. Solvents, hazing is still a thing that presents, and we're particularly keen on not letting that progress because of the significant organic brain damage can happen. So we're nearly finished. Exit outcomes, just providing treatment work. Well, certainly if we look at the 76 people who left our service last year, some of them just disengaged, and sometimes they will re-engage again. But if you look, 40 out of 76 had reduced their use at the time of leaving. And a significant number, 18, had actually become abstinent. So that is I suppose, progress for sure. And when we have looking at re-engaging, that's about people who re-engage with school, with connecting with family, maybe with sporting activities, etc. So there's more than just the drug use to consider. And the last slide now, the hub and spoke model that the National Clinical Programme is putting forward. The hope is that we'll have, instead of 2 kind of teams focusing on treatment with young people, we'll have 4, a new one in Cork, a new one in Galway, and that there will be a regional service where those hubs can offer offer support and advice to the people who are working in the smaller, more rural areas, the smaller population areas, so that we have a cohesive service where the advice can be stretched, particularly using technology, so that we can offer advice and support where it's needed. Thanks very, very much.
Thank you.